Hello guys, happy Sunday. Today it's TOGS. It is Thane Obstetrics and Gynecological Society. Welcome to the recurrent pregnancy loss on 28th June 2020 for a program on a wonderful webinar where we have got stalwarts from Thane city. As you all know, it's well known for Talaupali Lake, where the world goes for boating, and then it is followed by a trip to the Kopineshwar temple. It's popularly known also as Naupada Jamlinaka, and they say that the temple in Jamlinaka is known to fulfill all the wishes. It's a Ganpati Lord Ganesha's temple. So with invocation of Lord Ganesha, we start today's program webinar on recurrent pregnancy loss. And I request you to show the video which we have, a wonderful surprise video. Thank you so much. Your host, Dr. Niranjan Chavan, welcomes you for this wonderful webinar on recurrent pregnancy loss. And we have with us eminent stalwarts from Thane city. And here we see the lovely, wonderful video. Please, let's see what is Thane. So welcome to the Thane Obstetrics and Gynecological Society, the well-known place where the first train ran between Thane and the then Victoria terminus. As you saw, it is a city of lakes and beautiful places, lot of history. It is in the northeastern region of Salsette Island, and you saw the beautiful gate from where the Mumbai ends and we enter Thane city, and it's known for the well-known doctors. To begin with, it was a part of Mumbai Obstetric and Gynecological Society, but we had Association of Thane Gynecologists, which was led then by Dr. Prakash Pawar, and now it is a full-blown Obstetric and Gynaec Society headed by none other than the dynamic president, Dr. Rajiv Laul. Rajiv Laul, sir, is an honorary professor at Rajiv Gandhi Medical College, Kalwa, director of Renuka Nursing Home. He has a practice of more than 30 years. Well, he is also a half marathon runner and an avid singer. So welcome, Dr. Rajiv Laul, sir. We have the next speaker with us, a lady with poise and grace, Dr. Uma Bansal. She has been practicing in the Thane city for last 30 years, and she has come from Rajasthan University, has taken a diploma in reproductive medicine from Germany. She has her own Arogya Hospital and Uma IVF Center. She was also the ex-president, vice president, and treasurer of Thane OBGYN Society. Welcome, Dr. Uma. And we have a wonderful panel. And these panelists are the gems of Thane Society. Very well learned, very professional, and knowledge of wisdom and pearls of wisdom they have. Dr. Rajneesh Patel, I welcome, sir. He's a double gold medalist from Nair Hospital, 33 years in private practice, an associate honorary professor at Rajiv Gandhi Medical College, and he is also a course instructor in basic laparoscopic skills attached to Royal College of Surgeons UK and a visiting consultant at Jupiter and Kaushalya Hospital. Welcome, Dr. Rajneesh.
Thank you. We also have Dr. Ashutosh Ajgaonkar, who is a practicing OBGYN since 1991 and a teacher at Rajiv Gandhi Medical College for 20 years. Welcome, Dr. Ashutosh.
Yeah, thank you. Thank you.
Dr. Ashutosh.
Yes, thank you.
We have Dr. Sandhya Sharan, Sandhya Saharan, and she's a consultant obstetrician and gynecologist with a special interest in endoscopy, infertility, and yoga. She's also attached to Jupiter Hospital, Thane, Hiranandani Hospital, Medical Foundation, Cure IVF. Welcome, Dr. Sandhya. So may I hand over the platform to Dr. Rajiv to kindly take over.
Okay. Can I share my screen?
Yes, sir.
So good morning, everyone. The learning objective of this talk is to identify possible causes of early pregnancy loss, outline basic evaluation for recurrent pregnancy loss, and review current treatment approaches for these patients. The definition is the classical one being 3 or more consecutive pregnancy losses before 20 weeks of gestation, and the expanded one being 2 or more consecutive losses, because the risk of further loss is similar for 2 versus 3 consecutive losses, and initiation of evaluation is appropriate after 2 losses based on patient's age and desire. Epidemiology of recurrent loss: 5% of couples attempting pregnancy have 2 or more consecutive losses, while 1% have 3 or more consecutive losses. Most clinicians consider RPL even if the losses are not consecutive. Now, spontaneous abortions: 34% pregnancy loss is seen in prospective cohort of healthy women. 22% goes unrecognized, detected by assay only, while 12% is clinically recognized. The obstetrical history is predictive in that prior success there is 4 to 6% chance of loss, and in prior loss there is 19 to 24% chance of loss. A single spontaneous abortion, unless a successful pregnancy intervenes, increases the risk for next pregnancy, and then the distinction between sporadic and recurrent loss gets blurred. Effect of maternal age: the spontaneous abortion risk approaches 50% by the age of 40 for both aneuploid and euploid losses. Now, miscarriage recurrence risk: if there is no previous live birth with 1 prior loss, the recurrence risk is 19%. With 2 prior losses, the recurrence risk is 35%. With 3, 47%, and 4, 54%. But if there is a previous live birth, then with 0 losses, the recurrence risk is 12%. In 1, 24. In 2, 26. 3, 32, and 4, 26. Now, PCOS and pregnancy loss: there is increased pregnancy loss with PCOS. Prior treatment with GnRS agonist reduces miscarriages in PCOS women. RSA patients with increased luteinizing hormone, DHEAS or testosterone, are more likely to miscarry. GNS agonists decrease miscarriage rates in RSA patients with PCOS as compared to Clomid, the rate being 10% versus 55%. Coming to etiology and anatomical factors, there is 10 to 15 recurrent first trimester loss with congenital anomalies, and variations of double uterus being the most common. Septate loss accounts for 25 to 90%, but the septum is usually amenable to resection. In bicoordinate uterus, the loss range from up to 40%. There are surgeries available, the metroplasty is available, but the benefits of surgery are uncertain. With unicoordinate uteri, the losses range up to 50%, with diadal phase up to 40%. In utero DES exposure, many have abnormal uterine structure. Cervical incompetence, intrauterine synechia are some of the other causes. There is unclear relationship between uterine leiomyoma and RPL. Large submucal fibroids distort the cavity or occupy a large subendometrial area. The possible mechanisms being mechanical constriction or inadequate placentation resulting from poorly vascularized endometrium. These are some of the pictures of filling defects, a submucous fibroid, and a polyp in the uterus. Now, coming to infection. No infectious agent has been proved to cause recurrent pregnancy loss. There is increased colonization with uriplasma urolyticum in both cervix and uterus in cases of RPL, leading to empiric antibiotics. Certain infections have been associated with sporadic spontaneous losses, such as Toxoplasma gondii, rubella, HSV, CMV, measles, and Coxsackie, but they are not to be considered as the causes of recurrent pregnancy loss. Now, coming to the percentage of chromosomal abnormality by gestational age in genetic factors. The maximum abnormally chromosomal fetuses are seen by the gestational age of 12, and the chromosomal abnormality decreases as the gestational age increases. Now, trisomy being the most common genetic factor, counting for about 50% of cases. Trisomy 16, they are all lethal, and they constitute 1/3 of all trisomies. Trisomy 21, that is Down syndrome, usually due to meiotic non-disjunction with 80% maternal contribution. Monosomy X 20% with 40X Turner syndrome being most common. Triploidy 15%, where 90% contribution is from the father. tetraploidy 5%, mosaicism is 2%. Now coming to the parental abnormalities are seen in 3 to 5% of couples with recurrent loss. Balanced translocation being most common, reciprocal is seen in 60%, while Robertsonian is seen in 40%, with 25 to 50% risk of pregnancy loss. But these couples may eventually produce a normal offspring. Now there are speculations about single gene mutations affecting blastocyst formation, implantation, and morphogenesis of vital organs. Similarly, skewed X inactivation can be a factor. Preferential inactivation, that is more than 90% of one of the X alleles, may be lethal to a male offspring, may result in X autosome translocations and trisomy mosaicisms in the germline. Advanced maternal age impact on the risk for pregnancy loss cannot be overemphasized. Increased rates of maternally derived trisomies are seen. There is probable natural selection of better quality oocytes earlier in the reproductive life. Oocytes recruited later in the life are more likely to be abnormal or experience meiotic error. There is a decline in the number of oocytes from birth to menopause, while the fertility decreases while the miscarriage rate increases as the maternal age increases. Now coming to the thrombophilia as the etiological factor, pregnancy is a hypercoagulable state. Women with inherited or acquired thrombophilic disorders have significantly increased risk of pregnancy loss. Venous thrombosis seen in thrombophilia, it is most commonly inherited. Now the most common inherited factors are heterozygous factor V laden, G1691A, factor II prothrombin mutation, G20-210A, hyperhomocystinemia, that is methylene tetrahydrofolate reductase gene C670 and A1298C. Most common acquired are antiphospholipid antibodies, activated protein C resistance, hyperhomocystinemia. Other possible abnormalities being antithrombin deficiency, protein C or S deficiency, and elevated factor VIII. Now, arterial thrombosis is seen in hyperhomocystinemia, antiphospholipid antibodies, and lupus anticoagulant. Now, coming to factor V laden, abnormal factor V is resistant to anticoagulant effects of activated protein C. Majority of patients resistant to activated protein C will be heterozygous for factor V laden and is present in 3 to 8% of white population but rare in blacks and Asians. It is autosomal dominant. Acquired activated protein C resistance is seen in pregnancy with OCP use and in the presence of antiphospholipid antibodies. In heterozygous, lifetime risk of thrombosis is increased 7 times, while there is a 15-time increase during pregnancy or with OCP use. In homozygotes, lifetime risk for thrombosis is increased by 50 to almost 100%. In prothrombin G20-210A mutation, there is higher plasma prothrombin concentrations, augmented thrombin generation. In heterozygous, the incidence is 2 to 3% in whites. There is a conflicting prevalence studies among RPL, and recent critical reviews suggest an association. Hyperhomocystinemia polymorphisms, that is C677T thermolabile MTHFR, is heterozygous in 10 to 20% of whites with normal or slightly elevated homocysteine levels and increased homocysteine when combined with vitamin B deficiencies. Homozygous is seen in 10% of whites with significantly increased homocysteine. Now, A1298C often occurs with thermolabile 677T with a 33% frequency in Dutch population and decreased plasma folate levels. There is a significant association between hyperhomocystinemia and RPL. The mechanism being interference in embryonic development through defective chorion villus vascularization. There is a known association with later pregnancy-related complications. In antithrombin deficiency, now it is a physiological inhibitor of coagulation. With type 1, it is quantitative, decreased antigen and function, and is caused by gene deletions and nucleotide changes. Type 2 is qualitative by point mutation with single amino acid changes lead in heterozygous carriers. The into it is heterozygous carrier 1000. It is the most thrombogenic of inherited thrombophilia with increased risk of stillbirth the loss. In protein C deficiency, this protein C downregulates coagulation cascade. Deficiencies lead to unregulated fibrin formation. It is autosomal dominant with more than 160 mutations. Type 1 quantitative, type 2 is decreased function and is associated with second trimester losses. Protein S deficiency is a principal cofactor of activated protein. Mimic C deficiency with questionable association with pregnancy loss. Autosomally dominant with more than 160 mutations. Prevalence rate of 0.15 to 0.8% in general population. Luteal phase defect as an etiology of RPL is a controversial cause of RPL. Studies proving LPD as a cause LPD treatment improves pregnancy outcome. 80% of women with low mid-luteal progesterone proceed to term. 20% of fertile women have abnormal endometrial biopsies. Now coming to endocrinal factors, poorly controlled diabetes, over hyperthyroidism, overt hypothyroidism can be factors causing RPL, but there is no evidence that asymptomatic systemic endocrinological or metabological disorders are a cause of RPL. Certain autoimmune diseases are associated with pregnancy loss, such as systemic lupus erythematosus with a first trimester loss having 10% risk, second and third trimester loss 6% risk, and antiphospholipid syndrome, second trimester loss at 38%. Antiphospholipid antibodies are autoantibodies recognizing various combinations of phospholipid binding proteins or both. Antiphospholipid syndrome is a clinical association between APL and syndrome of hypercoagulability. Now it has clinical diagnostic criteria as well as laboratory diagnostic criteria. The clinical features being vascular thrombosis or loss of fetus at or after 10 weeks, or preterm delivery at or before 34 weeks, or 3 or more consecutive spontaneous abortions before 10 weeks. Laboratory features being antiocardiolipin antibodies, IgG or IgM at moderate or high levels on 2 or more occasions at least 6 weeks apart. Lupus coagulant antibodies detected on 2 or more occasions at least 6 weeks apart. Other antiphospholipid antibodies such as antiphosphatidylserine nearly always is associated with APS and is highly correlated to cardiolipin binding. Other antibodies have less correlation. Now, low levels of APL are not associated with RPL, and assays for non-ACL APL are not standardized. Studies thus far are contradictory. Anti-nuclear antibodies may be more common among women with RPL, but their presence or absence do not predict subsequent pregnancy outcome. Other autoantibodies not associated with RPL being antithyroglobulin and antithyroid peroxidase. These are the markers for increased risk for pregnancy loss if identified early in pregnancy. Some small studies suggest a slight association in RPL, but other larger studies do not. Subsequent pregnancy outcomes are not affected. Coming to alloimmune factors, that is immune response to non-self components of pregnancy, that is cytotoxic antibodies, absence of maternal blocking antibodies, inappropriate sharing of HLA, and disturbances in natural killer cell function and distribution. Now, cytotoxic antibodies are a maternal response to paternal antigens. They are present in normal pregnancies. They are more common in fertile couples than those with RPL, and they have no bearing on subsequent pregnancy outcome. Blocking antibodies. The theory is that maternal antifetal antibodies block maternal cell-mediated response. If it is absent, then fetal rejection occurs. They are not present in normal pregnancies, but they are often present in RPL, and they are detected by non-specific mixed lymphocyte response assay. In animal models, beta cell deficient mice have normal pregnancy outcomes. Human gamma globulinomics have successful pregnancies, and presence or absence is not predictive of subsequent outcome. Parental HLA sharing. The theory is that the parents are antigenically similar. Mother is less likely to develop blocking antibodies. Studies are contradictory. Some show increased sharing in HLA-B and HLA-DR loci. Most show no associations. Coming to natural killer cells, CD56 plus NK-like cells secrete a transforming growth factor beta-like substance crucial to the maintenance of pregnancy. These are present in endometria and early gestational decidua of women with RPL. Murine models show activation of NK cells increases the rate of abortion, and depletion of NK cells have opposite effect. Human studies show no association of testing at successful pregnancy. T helper, that is Th1 immunodystrophism. Here is that aberrant or inappropriate Th1 stimulation may result in overproduction of cytokines that have deleterious effect on conceptors. Dichotomous Th1 versus Th2 cytokine profile is associated with human pregnancy loss and success. Now coming to the environmental factor, with confirmed association in ionizing radiation, organic solvents, alcohol, mercury and lead. Suspected association is seen with increased caffeine ingestion more than 300 milligrams per day, hyperthermia and cigarette smoking. Unknown association with pesticides. Now these are some of the environmental factors, but convincing evidence in their association with RPL is lacking. Now coming to the idiopathic etiology, more than 50% of couples with RPL have no explanation despite extensive evaluations. Informative and sympathetic counseling appears to play an important role. 70% live birth rates are reported in couples with unexplained RPL who undertake an untreated subsequent pregnancy. Now coming to history, first is to study the pattern and trimester of pregnancy losses and whether a live embryo or fetus was present. If there is an exposure to environmental toxins or drugs, are there any known gynecological or obstetrical infections and features associated with APS? Is there a family history of RPL or syndrome associated with embryonic fetal loss? Previous diagnostic tests and treatments. Complete general examination, general physical examination and detailed pelvic examination, to be followed by various tests such as saline sonogram, hysteroscopy, and nowadays 3D sonography. Hysterosalpingogram. Previously we used to do luteal phase endometrial biopsies to be repeated in next cycle if abnormal, not done nowadays. Placental fish analysis, placental karyotypes, lupus anticoagulant, anticardiolipin antibodies, both IgG and IgM. This is an example of PGD aneuploidy seen in fish technology in trisomy 21 and in monosomy 21. Now antiphosphatidylserine serine antibody, IgG and IgM, platelet count, thrombophilia mutations and functional assays, thyroid stimulating hormone are also studied. Tests that are not useful are other antiphospholipid antibodies, anti-nuclear antibodies, maternal anti-paternal leukocyte antibodies, mixed lymphocyte maternal paternal cell cultures, HLA genotyping, mouse embryo toxicity assays, and immunophenotype panels. Coming to the treatment, in thrombophilia, for inherited or acquired thrombophilia, heparin anticoagulation is advised. For bona fide APS, multiple studies support the use of heparin and aspirin, with aspirin dose of 81 milligrams orally per day and subcutaneous heparin 10,000 to 20,000 units per day in divided doses. Alternative is low molecular weight heparin 2,500 to 5,000 units per day in a single dose with calcium supplementation. Now, for elevated hyperhomocystinemia without thrombosis history, supplementation with B6, B12 and folic acid in combined form, and heparin anticoagulation for history of thrombosis or homozygous MTHFR mutation or pregnancy outcomes unresponsive to vitamin supplementation. Thank you.
Thank you, sir, for a wonderful presentation. You have covered RPL very nicely. We will get back to you with questions later. Thank you so much. It was a wonderful insight and going through all the causes and etiological factors. And you have nicely explained the treatment, the management, and how to diagnose RPL. Now, sir, we will go to the next speaker, Dr. Uma Bansal. He is going to speak on low molecular weight heparin in the management of recurrent pregnancy loss. The mic is yours, Dr. Uma Bansal. Thank you.
Good morning, friends. I thank TOG's Managing Committee and Bridging Bharat, Dr. Narendra Chavan, for giving me this opportunity to talk on an important subject of thrombophilia and recurrent pregnancy loss. Sir, just give me a minute.
I think it's very important that today recurrent pregnancy loss has been the mainstay of our practice, and we get about 20 to 30% of such cases with abortions, more than 2 or 3, and they are running from pillar to post, and it's very difficult to diagnose. So we have expert and stalwarts with us who are going to go and discuss their experience. So it's very important that we can go ahead and try to understand recurrent pregnancy loss. I would like to share, when I was a resident in Sion Hospital, we had a bad obstetric history and bad obstetric history OPD, and we used to get many cases during that time. And I remember my unit head chief, Dr. P.K. Shah, used to guide us, and there were a lot of studies which were coming, and all that we will discuss. But for now, we have the use of low molecular weight and recurrent pregnancy loss, and we have Dr. Uma Bansal to share her experience and her lecture. Dr. Uma, you can go ahead.
Good morning, friends.
Yes.
Recurrent pregnancy loss.
Yes.
In pregnant population, incidence of RPL is 0.4 to 1%, though some literature claim it to be 2 to 3%, and only in 50% the cause can be determined. Cause can be uterine, immunologic, endocrine, genetic, thrombophilia, environmental. Thrombophilia incidence is 0.2 to 0.3% in pregnant population. In world, at a time, around 213 million females are pregnant. And if I say thrombophilia incidence is around 6.3 lakh females suffer from thrombophilia. Who should be investigated for thrombophilia? Women with 3 consecutive abortions with or without live birth. Women with 2 abortions after documented presence of FHR, age more than 35 years, and who had difficulty in conception. History of thrombotic episode in past. Pregnancy is a hypercoagulable state and it is worsened by thrombophilia. Thrombophilia causes impaired blood flow, thrombosis of placental vessels, leading to placental clots and underperfusion of placenta, fetal growth restriction, and fetal demise. Thrombophilia, it can be inherited or it can be acquired. Inherited, where there is abnormalities of procoagulant factor like factor 5 leading, factor 2 prothrombin mutation, G20210A, where guanosine is replaced by adenosine, plasminogen activator inhibitor, deficiency of endogenous proteins like antithrombin 3, protein C or S. Other inherited factors are hyperhomocystinemia. Or 5 prothrombin, antithrombin protein C and protein S can be acquired also. ASHRAE guideline 2017, unless in the context of research or in women with additional risk factor for thrombophilia. But they recommend screening for antiphospholipid after 2 pregnancy losses and screening for anti-beta 2 GPI1 after 2 losses. Acquired thrombophilia, it is a disorder of immune system where body recognizes negatively charged phospholipids on cell membrane as foreign and produces antibody. It is characterized by excessive clotting of blood, thrombocytopenia, adverse pregnancy outcome due to inhibition of trophoblastic function and differentiation, activation of complement pathways at maternal fetal interface, in later pregnancy, thrombosis of the uteroplacental vasculature. It can be primary or associated with other autoimmune disorder like SLE. APA binds to endothelial cells and platelets, causes platelet activation aggregation, which causes coagulation. How do we diagnose APLA? There are 2 criteria, clinical criteria and laboratory criteria. Clinical criteria, 1 or more demise of a morphologically normal fetus at or beyond 10 weeks, 1 or more premature birth of normal fetus before 34 weeks of pregnancy due to preeclampsia or placental insufficiency. Mild preeclampsia in 15% and severe preeclampsia in 50% cases. 3 or more unexplained consecutive miscarriage of less than 10 weeks gestation where other causes are ruled out. 1 or more clinical episode of thrombosis of any tissue or organ. Laboratory criteria, lupus anticoagulant antibodies detected on 2 or more occasions at least 12 weeks apart. Anticardiolipin antibodies IgG or IgM at moderate or high level more than 40 GPL on 2 or more occasions at least 12 weeks apart. Anti-beta 2 GPI antibody IgG or IgM in blood on 2 or more occasions. To diagnose APLA, at least 1 clinical and 1 laboratory criteria must be present. This is normal coagulation cascade and it is showing site of heparin 83 complex which works on factor 10A, prothrombin, thrombin and factor 13A. What are different types of anticoagulants available? Anticoagulants play key role in management of thrombophilia. And different types of anticoagulants are available with different mechanism of action. Thrombin inhibitors, indirect inhibitors is heparin, which is low molecular weight heparin as well as unfractionated heparin. LMWH or unfractionated heparin is the drug of choice as it does not cross placenta, so safe for embryo. Heparin, which contains 13 or more saccharide units, it acts with 83 complex on thrombin and factor 10A, while low molecular weight heparin acts to inhibit factor 10A and requires binding only with 83. Low molecular weight heparin. It is an enoxaparin sodium salt and it has antithrombotic properties. It contains lower portion of pentasaccharide than parent compound heparin. Its bind to antithrombin 3 lead to inhibition of factor 10A and 2A. Its effect is more on factor 10A than 2A. In clinical doses, no effect on platelet reactivity, that is platelet aggregation, fibrinogen to platelets, prothrombin or APTT. It is not inactivated by platelet factor 4 as heparin. Therefore, activity extends to factor 10A, which is bound to platelet membranes. Maximum effect is 3 to 5 hours after subcutaneous injection. It is metabolized in liver and excreted by kidney. Dose of LMWH is dependent on weight and creatinine clearance. Age and gender does not have any effect. What precautions should we take? All patients should be evaluated for bleeding disorder before starting LMWH unless needed urgently. Routine monitoring when on medication is not required, and reversal of action can be done by protamine sulfate 1 mg for 1 mg of LMWH. Used with caution in patients with history of heparin-induced thrombocytopenia. Unfractionated heparin. It is inactive by itself as an anticoagulant. It potentiates the action of 83. And heparin 83 complex neutralizes the action of factor 2, 9, 10, 11, and 13. It displaces platelet factor 4, a protein that neutralizes heparin. Routine monitoring is required by APTT. A clotting time of 1.5 to 2.5 times the normal mean APTT value is therapeutic. Initially, the APTT should be measured and the infusion rate adjusted every 4 hours if IV heparin is used. Once a steady state is achieved, daily monitoring is sufficient. It is a comparative study between LMWH and UFS. I am repeating because it is very significant slide. Molecular weight of LMWH is 4,200 Dalton, while heparin it is 3,000 to 30,000 Dalton. Activity against factor 10A is to 2A is greater with enoxaparin, it is 4 is to 1. Equivalent with heparin 1 is to 1. Bioavailability is 92% with LMWH, while with heparin it is only 30%. Half-life is 4.5 hours, with heparin it is only half to 1 hour. Binding to plasma, platelets and vessel wall protein is less, so improved predictability of dose response relationship with LMWH, while with heparin it is less reliable. Regular monitoring is not required in majority of patients, while with heparin it is required. Heparin-induced thrombocytopenia, very low incidence. With UFH, it is high incidence. Administration subcutaneously, while UFH is IV hospitalization and trained staff is required. Chances of osteoporosis on long-term use with enoxaparin, it is very low because there is a reduced binding to osteoblast, which results in less activation of osteoclast and reduced frequency of osteoporosis. With UFH, there is a high chances of development of osteoporosis. Inhibition by platelet factor 4, no, yes. I'll come back now to APLA again, which is acquired thrombophilia. Management of APLA. Aim to maximize chances of successful maternal and fetal outcome. To prevent thrombosis in mother. To ensure good counseling and planning for future pregnancy. Postpone pregnancy if thrombotic event has occurred in last 6 months. Substitute LMWH or UFH for warfarin at time of missed period. Low dose aspirin before conception because aspirin acts by selective inhibition of thromboxane. different mechanism. Anticoagulation. Patient on warfarin should be switched to heparin as soon as pregnancy is confirmed. Need therapeutic dose, that is need 7,500 to 10,000 units twice daily. Stop heparin 24 hours prior to induction of labor or C-section. No regional or epidural anesthesia for 24 hours after last dose if patient comes in labor. Anticoagulation to restart 6 hours after vaginal delivery. Bleeding. A case study of EPLA with prior thromboembolism with RPL. 33-year female, G3A2L0, known case of DVT, SLE and EPLA syndrome, LA, ACA and ANA positive. History of DVT both leg, left leg in 2014 and right leg 2018. Angioplasty for CAD done in 2017. First IUFD at 14 weeks in 2017. Second twin live pregnancy, MTP done in 2019. Third is present pregnancy of 31 weeks. She is on SCQ 200 milligram OD, Vicilon 5 milligram, Ecospin 75 milligram, and LMWH 60 milligram BD from 5 weeks of pregnancy. It is started from 5 weeks of pregnancy because patient was warned not to conceive. So she came on bleeding with showing sign of early IUGR with normal Doppler, but we are continuing 60 milligram on OD only. I'll give you feedback once she deliver. Pregnancy with EPLA with RPL, but no history of thromboembolism. Need only prophylactic dose, that is LMWH 40 milligram subcutaneously daily or UFH 5000 units subcutaneously 12 hourly as soon as viability is confirmed and continue till delivery. Low dose aspirin is from time of confirmation of pregnancy. 2015 RCOG guideline, antenatal and postnatal prophylactic dose of LMWH. If female weight is less than 50 kg, 20 milligram daily, weight between 50 to 90 kg, 40 milligram daily, 90 to 130 kg, 60 milligram daily, 130 to 170 kg, 80 milligram daily. Pre-pregnancy counseling in women with EPLA. Start low dose aspirin, preconception. Anticoagulation profile should be discussed in advance, and pregnancy induced possible complication like missed abortion, severe preeclampsia, IUGR should be discussed in advance. Woman with RPL but low titer of EPLA does not require any treatment. Antepartum surveillance. If history of first trimester losses, then do USG weekly till progress beyond point of prior loss. If history of second trimester fetal loss, serial USG 3 to 4 weekly testing is required. 30 to 32 weeks onwards, daily fetal kick count, bi-weekly non-stress test, weekly biophysical profile. Calcium and vitamin D in heparinized patient, the dose should be increased to 600 milligram BD along with vitamin D to increase absorption of calcium and reduce risk of osteopenia. Postpartum anticoagulation, prophylactic LMW UFH for 4 to 5 days, plus warfarin 5 to 10 milligram for 6 weeks. Weekly PT-INR monitoring is required and target should be 2 to 3. A word about IVF and thrombosis, that is APLA. IVF is a potentially dangerous since ovulation induction regime triggers an estrogen-induced hypercoagulable state. If IVF is performed in a woman with a history of thrombosis-associated APLA, she should be switched from their usual oral anticoagulant to therapeutic dose of LMWH, which should be maintained after oocyte retrieval. If the patient conceives, she should be continued to LMWH. Thrombophilia other than APLA. Dr. Laul has discussed in detail. Antithrombin deficiency causes early fetal loss, severe PET, IUGR or abruptio. Protein C and S deficiency again can cause fetal loss, PET, IUGR and abruption. Prothrombin gene mutation is due to a specific gene mutation in which guanosine is changed to adenosine nucleotide at position 20210 and causes 30% increase in prothrombin level. Alteration of the factor V molecule at APC binding site impair or resist APC's ability to degrade or inactivate factor Va. Protein C and S deficiency, whether inherited or acquired, may cause thrombosis when level drops to 50% or below. And protein C and S level decreased in pregnancy, OC pills, warfarin, liver and renal disease, acute thrombosis, DIC. Hyperhomocystinemia, it is inherited or acquired. Homocysteine levels are increased by deficiency of folic acid, vitamin B12 and vitamin B6. So always use combination pill. And levels in blood are severe, moderate or mild. Philic women should be planned and managed individually. Screening for congenital alloimmune factors, immune response to known self component of pregnancy, that is cytotoxic antibodies, absence of maternal blocking antibodies, inappropriate sharing of human leukocyte antigen, disturbances in natural killer cell function and distribution. And most of these patients, after they are treated for this factor, require LMWH because they are prone to thrombosis during pregnancy. Thank you very much. With this, once again, I thank TOGs and Bridging Bharat, Dr. Chavan and Dr. Rajiv Laul. Thank you.
Thank you so much, Dr. Uma. It was a wonderful presentation, and we can hear the claps, and those claps are by all the panelists who are there, but I would specifically like to invite now few questions for our esteemed panelists. Dr. Rajneesh Patel, you wanted to comment on something on Dr. Rajiv Laul's lecture. Dr. Rajneesh, can you hear me? Well, I think we will get back to Dr. Laul later. Thank you, Dr. Uma. You have nicely explained the presentation on low molecular weight. And now I would like to introduce you the Secretary of Thane Obstetric Gynec Society, none other than Dr. Datta Panandikar. Well, he is the silent guy. He is always the man behind the show, and we have been working for this RPL webinar for last 20 days, obviously helping hand for Dr. Rajiv Laul. Dr. Datta is very well known in our Mumbai obstetric gynec circuit, very humorous, very lively person, and Zinda Dil. He comes from JJ hospital groups, and we have fun when we come and meet in Foxy webinars and CMEs and conferences. He is attached to Kaushalya Hospital, and he has his own clinic and hospital. And I remember, I think his wife is a wonderful poet. Dr. Datta,
Yes, thank
you
you
can
very much.
add, yes, you can add some few points on Thane if I have missed out the wonderful city of Thane.
Now we are progressing into a smart city now,
Very good.
and we have of course been changing commissioners like we changing hats, but everybody else is doing good work. We have a 1,000-bed COVID facility at Balcom, and we just heard in the newspapers today that we are going to have another 1,000-bed facility, but I'm not sure from where they are going to get the doctors and nurses. That's the problem. So anyway, Thane is grouping and fighting this COVID virus. In fact, one of my hospitals has been converted into a COVID maternity facility, and I've got the unique distinction of being the first gynecologist from Thane to give my hospital for the same. They say that slowly, one by one, all other hospitals will be added area-wise. But at present, I'm the only one, and we have a team which is managing the COVID pregnant ladies. We have delivered more than 20 ladies in the last 10 days, and most of them have gone home. So, touch wood, everything is going well. Thane is geared up very well to fight these cases. But if you see in the last 3 days, the cases have really spiraled. They have never gone about to 200 to date, but in the last 3 days, there have been 264, 365 and 371 cases. So I don't know what is going wrong whether this unlocking has worsened the number of cases, but we are absolutely fighting this virus now. Thank you.
Absolutely, Datta. So nice of you to join us and be a part of this recurrent pregnancy loss webinar. And I'm sure we all are COVID warriors, and we are going to fight this out. Sooner or later, this is going to disappear from the earth surface, and we will be all winners. It's question of time. So now we come back to the recurrent pregnancy loss, and I got many questions down there, and we start with our first panelist. Welcome, Dr. Rajneesh Patel. I hope you can hear my voice. And
I hope I am also audible.
yes, thank you so much, sir. Well, with your experience of 33 years and wonderful practice in Thane Obstetric Gynac, we would like to hear from you what are the various treatment options and pregnancy outcome in women with idiopathic recurrent miscarriages. The mic is yours, sir.
Well, as we have been taught since our study days, that treatment always depends upon the etiology, but that has already been covered by Dr. Lowell and Dr. Bansal. You are asking me about idiopathic recurrent miscarriage. The treatment options today are basically low molecular weight heparin, low dose aspirin, progesterone, folic acid, and in some cases they have started using prednisolone. And in fact, prednisolone has been used in the dose of 20 milligrams per day for the first 12 weeks. So if you get a fourth recurrent abortion, maybe you should add prednisolone to all the other drugs that I have talked about. And I would advise that the progesterone be continued only for the first till the end of the 12th week. There is no need to give. I have seen prescriptions of progesterone going into all 9 months. I definitely don't agree with that. Only the first 12 weeks, end of the first 12 weeks, you can stop the progesterone and then continue with folic acid, low dose aspirin, and low molecular weight heparin. Also, I would like to point out to the audience that low dose aspirin is now no longer 75 milligrams. Low dose aspirin is now 100. Maybe we'll come to that discussion sometime later.
Okay.
Why it is 150.
So there are articles also by Daya and Goldstein et al. And they have demonstrated the use of progesterone significantly, especially in idiopathic recurrent miscarriages. The exact mechanism is difficult to explain, but even a study by Mohammad Fauzi has been done, a randomized placebo-controlled study, which was published in 2008, where they have come out with the treatment options and pregnancy outcome in women with idiopathic recurrent miscarriage. So thank you so much, Dr. Rajneesh. You have answered very wonderfully. Dr. Rajiv Lawal, we
Yes,
come
sir.
back to you now. What a wonderful presentation you went through and explained regarding recurrent pregnancy loss. But I want to ask you something on low molecular weight. You know, we want this mix and match combination here. So, how effective is low molecular weight heparin in improving the live birth rate in patients with two or more consecutive unexplained recurrent pregnancy loss? What is your take on this, sir?
Hello. Yes, clinical data has indicated usefulness of low molecular weight heparin in women with unexplained recurrent miscarriage. A prospective randomized study about administration of low molecular weight heparin and aspirin to these cases was conducted by Dolitsky, where 104 women were randomized as 40 milligrams enoxaparin group and 100 milligram aspirin group. And as soon as fetal cardiac activity was seen, the prophylaxis was started. The live birth rate was 81.5% in enoxaparin group and 84% in aspirin group. Similarly, Fauzi et al. Achieved a live birth of 81% using enoxaparin 20 milligrams a day with patients with 3 or more fetal losses or of unexplained etiology. So, an improvement in outcome as reducing early and late spontaneous abortions for women with recurrent pregnancy loss of unexplained etiology treated with LMWH over no treatment was when LMWH was given throughout the pregnancy. The consensus is that the combination of low molecular weight heparin and aspirin is superior to aspirin alone in achieving more live births. Therefore, it is the recommended treatment for recurrent miscarriages with antiphospholipid syndrome.
Okay, that was a wonderful explanation, sir. And I agree with you that there have been studies been done, and it is recommended treatment for recurrent miscarriages with antiphospholipid syndrome. And there are various studies which have been done. I recollect Ahmed Badawi, who had come in 2018, and Dr. Komal had done a wonderful program on recurrent pregnancy loss, and the whole crowd was filled, about more than 300 members in the evening, and he had given a wonderful lecture. And he has a study also which was published in 2008 in the journal Obstet and Gynecol, that is regarding low molecular weight heparin in the patients with recurrent early miscarriages of unknown etiology. A wonderful guy and a wonderful presentation he gave. It just recollected me the way you have presented today. Thank you so much. Dr. Sandhya Saharan, we come back to you. How are you today?
Absolutely fine, Niranjan. Thank you so much.
So I hope you had a wonderful session of yoga in the morning. We saw that last weekend. What a beautiful video you have presented to the whole Foxians, and it has gone viral.
Thank you so much.
On the International Women's Day, and really I appreciate the level of fitness you all members have. I can see Rajneesh Patel, Rajiv Lawal doing a yoga session also. When I visited on the Thane OBGYN Society WhatsApp group, and we are trying to be fit. I think this lockdown has changed our whole perspective, and we have got time for ourselves to look for our own health. So that was something a breakthrough. Actually, I have also lost 10 kgs. I'm not the one which you used to see me before. So things have changed in everybody's life, and I hope it changes good. And I'm seeing you, such a wonderful personality. I remember when we were in Wadia and I was there, and you were a resident in the unit. Dr. Kanbur was also there, and we had a wonderful time in Wadia. Wadia is like a symphony orchestra. When patients are delivering, and you have those babas coming from one side with a tray, and the other side you have the curtains and the drapes being placed. It was wonderful to do all those episiotomies and delivery in Wadia maternity. I have wonderful memories with you. Sandhya, thank you so much for joining with us.
Yes, Niranjan.
Come back to RPL. You would like to say something of those memories before we go ahead with the continuation of the question?
Yes, they're wonderful memories, Niranjan, definitely. But what I can see is I've seen you since you were almost 17, 18 to what you are today. I have seen your growth, and congratulations. I also know that you are now joint treasurer of Foxy as recent as yesterday. So congratulations to you. We've all grown, and now we are all batting the COVID era. successfully. You're the frontline runner at Science. So we hear so much about it, and I think your weight loss is highly contributed to that episode also. But I wish you take care, and I wish we all take care. And we have found time for heparin in this early morning. So that's good.
Thank you. So the question is, should thromboprophylaxis be given throughout the pregnancy in women with previous history of recurrent miscarriages of unknown etiology? What is your take on that?
See, Niranjan, now I'd like to divide this into two parts. One is unknown etiology. Okay, so now we all know unknown etiology accounts to almost 50% of recurrent miscarriages. Now, even if you do not treat, it is known that 60 to 70% of pregnancies are successful in these patients. So what do? You cannot sit on the fence and tell a patient. I'm speaking from a purely clinical point of view. A patient walks in, she says, I've had 2 consecutive miscarriages or 3. So you start working up, you find out everything. You have ruled out APS. Naturally, it is unknown, so you know that there is no positive factor. You ruled out everything. So what do you offer her? You will give her folic acid, progesterone, everything, whatever. But the thing is, if you give her only aspirin or you give her only low molecular weight heparin, so they say combination always works better because the meta-analysis, which Dr. Laul has also enumerated now, it shows that there is a definite increase in the live birth weight. So I would give it in conjunction rather than give it in isolation. But yes, we have to give it throughout pregnancy. That is always better. Like Dr. Bansal has elaborated, we stop it 24 hours before the delivery and we continue again 12 hours post a C-section or a delivery, and at least I would say 2 weeks I continue the patient on heparin. After that I can switch her on to warfarin if indicated. Otherwise I stop it after 2 weeks. Some studies say you continue for 6 weeks. So if the question is throughout pregnancy, yes, you start and continue it throughout pregnancy.
Well,
Now
that
it
was
is
so
also
nice.
dose
Yes.
dependent. That is very important. Is like you mentioned in a slide. There are a lot of people who give 40 milligrams. But if your patient is 100 kgs, then you have to remember that 40 milligrams is not going to be enough for her. Step it up to 60. So that is very important. And monitor her. You just cannot keep a patient on heparin and say, okay, fine, let's see. Like Dr. Bansal said, keep monitoring her parameters, her hematological profile. So this is very important that you start heparin, but you have to explain the pros and cons to the patient also.
So nicely explained, Dr. Sandhya, and you've done justice to the question. Wonderful. Thank you so much. Well, we go to the second round. Well, we have Dr. Uma Bansal been there. What is your take on natural micronized progesterone? Is it beneficial to women who are bleeding and they have history of more than 3 miscarriages?
If a woman is having more than 3 miscarriages and she is bleeding, she requires progesterone therapy. In Fertility Studies Journal of 2017, where a paper is presented by ESRAM, and they have conducted 10 trials where 8 studies were done, and they have found that women who were having recurrent miscarriage, they improve live birth rate by giving progesterone. They have tried with the micronized progesterone, dihydrogesterone, synthetic progesterone, hydroxyprogesterone, caproate. And they found that it does not affect does not disturb genital abnormality in the fetus or baby, does not have any effect on preterm labor, but definitely live birth rate is improved. Here I will answer one more question, because they have mentioned that hydroxyprogesterone caproate is superior than micronized progesterone and dihydrogesterone. And I will answer Dr. Rajneesh Patel question that I give hydroxyprogesterone caproate till 34 weeks pregnancy, because it not only prevents recurrent miscarriage, but it prevents preterm labor also. So I hope I answered your question well.
You're
that it
entitled
works
for
very
your
well.
opinion, but I'm sure there are various other studies. I would like to name here Haas, who has done also a Cochrane database systematic review in 2013. There is also Palagno, who has done the study on micronized progesterone. And there are various studies which are going to be telling us that yes, it does help. We have to go ahead and use. What is your take? When do you start this drug, micronized progesterone, to be precise? When do you start? Which week of period of gestation you would like to start in the first
Once
trimester?
intrauterine pregnancy is confirmed, if a patient is having previous history of recurrent miscarriages, I do even their serum progesterone level once their urine pregnancy test is confirmed pregnancy. And if progesterone level is low, less than 15, then I'm sure she need definitely therapeutic dose of progesterone. It is not empirically that I'm starting.
Okay, okay. So we will come back to you. Wonderful answer. Dr. Ashutosh Asgaonkar, how are you?
Sir, fine, fine.
Yeah, I remember
All
those days when I had come to the Rajiv Gandhi Medical College and we had taken exams, and there were Dr. Pathare, yourself, and we had a wonderful time. I think that was probably 15 years ago, if I'm not
maybe.
mistaken. Yes,
Yes, it's long time back.
yes, and you look the same.
Yeah,
Yes, so nice.
Kailash Jivan. नहीं काय what?
Chavanpraj, Chavanpraj.
Chavan Prash.
Prash. So I'm feeling so happy to meet you. I think we are meeting in person probably or on webinar, probably after a decade. And it's been so nice that you are very active in Thane Obstetric Gynec. Actually, all of you are doing wonderful job. And I'm very much sure that many Thaneites are watching this program. And salam to them. They are all COVID warriors doing wonderful job. So Dr. Ashutosh, let's come back to RPL. What treatment do you suggest for a woman who is positive APS, and when to commence this treatment? And when you start this treatment, what will be the dose you prescribe?
Mm-hmm. Okay, first of all, doing just anticardiolipin antibodies one time is not diagnostic. You have to repeat it again after 12 weeks. And again, if they are indeterminate or high levels, then you say that it is anticardiolipin. Now, basically, we check for three. We check for lupus anticoagulant, we check for anticardiolipin antibody, and we check for anti-beta 2 GPM. Now, you can have several scenarios. You can have all the three positive, or you can have one of them positive. Now, if all the three positive is not very good, because in the pregnant study, they have found out that whatever you do, only you are going to get 30% live birth. The rest, the 70% are still going to end up with an abortion, whatever you do. But that is only if all the three. The next bad thing is the lupus anticoagulant. Now, amongst the three, the worst thing is the lupus anticoagulant. Now, so many things have been studied. Now, one study has said that if you start the aspirin, low-dose aspirin, pre-conceptional, now that is working much better because it helps in implantation as well. Also, there have been 4 major multicentric trials using aspirin, and they're comparing aspirin, then aspirin plus heparin, and then both. And then what has happened is the 2 major Habenox trial where they compared heparin and aspirin and a placebo, and they found out that there was no difference. Then there was a A-Life trial where they had 3 arms. They had aspirin, then aspirin plus low molecular weight heparin, and a placebo. And again, they found that there was absolutely no difference as far as the live birth is concerned. But 2 other trials, definitely they gave thumbs up to aspirin plus heparin. So the jury is still out. We still don't know. There have to be more evidence to just say that what can be given. But definitely, I would say some amount of thromboprophylaxis is required in the recurrent pregnancy loss, which is attributed to cardiolipin antibodies. And it is your choice whether you can give aspirin or heparin. Maybe aspirin plus heparin is better, but if you are giving aspirin, it is better you give preconception. Heparin can be given, there is no definite when can be given. You can give it as soon as you check the heart. When the heartbeat starts, yes, you can start it. And then it can be continued as per if there are associated thrombosis episodes, then definitely it has to be continued till delivery. And otherwise, it can be stopped at 34 weeks, like Dr. Lowell said. Thank you.
Okay, and I think even heparin can be given self-administered subcutaneous injection. It is, as you have already said, that the fetal heart activity is one seen, and you can give in a dose of 5,000 international unit twice a daily. So that is what is your take, and you have wonderfully described the different arms and the studies which have been done. And I'm sure it is going to be very helpful in your practice, and you have already shared your experience. Thank you, Dr. Ashutosh. We will get back to you soon.
Yeah, thank you, sir.
And I come back to Dr. Rajneesh Patel. Sir, Dr. Rajiv Lawul has wonderfully given a lecture of recurrent pregnancy loss, but we have few users who have already joined later on after his lecture. And I want to tell you and reiterate this Sunday morning, we have got more than 510 users logged in and are seeing you live. So they want to know from you what are the different tests which are to be done for the diagnosis, which you recommend for RPL, and can you just summarize all those factors which are there, and what are the ultrasound or whatever the modalities which are available, or any blood test would you like to do, and in brief, what treatment option would be a better thing for such patients? Thank you so much, sir.
Niranjan, that will require another talk. Your question is so huge.
Yes.
that I'll have to be given a half an hour slot for that. But jokes apart, if you know the etiology of the whole situation that we are dealing with, which we know in at least 50% of the cases, which is not bad. Half the time, at least, we know what we are doing. Based on the etiology, you can just write down all the investigations that one would like to do in a patient like this. Before I start with the investigations, one thing I don't know whether, I think Dr. Lowell had mentioned that the age of the patient and previous history of abortions, these two things are independent factors in the causation of RPL, irrespective of every other factor. So what we need to tell the community in general is to try and get pregnant as early as possible, because this is an independent risk factor for recurrent pregnancy loss. Obesity is another risk factor for recurrent pregnancy loss. Now, the rest of the things we have already seen. We have talked about APLA, genetics, anatomical, endocrine. 2 or 3 new things that I would like to touch upon is the recent studies have started showing that PCOS can be a risk factor for RPL, and one of the mechanisms being proposed is insulin resistance and hyperandrogenemia. So you can include that in your battery of tests. There are also the research tests going on natural killer cells, where we have peripheral natural killer cells and uterine natural killer cells, and a lot of debate is going on about the natural killer cells also. Cytokines, infections, although TORCH has been abandoned almost completely, there is some evidence that bacterial vaginosis can be responsible for late recurrent pregnancy losses, probably second trimester of pregnancy losses. Thrombophilia, Bansal madam has given a huge talk on that. So depending upon all these, I would recommend starting with your basic investigations like your CBC and blood sugar levels, especially HbA1C, thyroid profile, prolactin. These are your basic things. And then go on from there and include all the etiological factors. So that would include a nice transvaginal sonography or a 3D sonography. If something is found on the 3D sonography, one should include histolaparoscopy in the investigation, taking care that the person who is doing the histolaparoscopy is a qualified histoscopic surgeon as well. You don't want your patient to undergo two anesthesias. If there is a septum, he can deal with the septum on the table. Other investigations would be, as Dr. Ashutosh has said, about the APS, that is antiphospholipid, lupus anticoagulant, ACA, ANA, all of which should be 2 reports 12 weeks apart. That has already been emphasized. In addition to that, I would like to do a pap smear just to rule out any vaginal infections in this patient. The most important investigation that most webinars are not touching upon. Am I audible to everybody?
Yes.
Yes, sir. Yes, sir. You are audible. Just speak little louder.
Okay. So most people do not touch upon this, and that is the male factor. I request everybody who is listening to me to please see to it that you include the male factor in the investigations of recurrent pregnancy loss. I think that DNA fragmentation test is a must in all cases of recurrent pregnancy loss. Let the audience be warned that just a normal semen assay, even if it is normozoospermic, completely normal semen assay, is not a guarantee of ruling out the male factor in RPL. So DNA fragmentation test, I think, is a must, in addition to all the other tests which most people are already very, very well versed with. And depending upon the cause that we find, we give the treatment. We have already talked about that. Immunotherapy, we have talked about APLA, we have talked about anatomical structures. Diabetes mellitus is another thing that people tend to forget. A strict glycemic control goes a long way in preventing recurrent pregnancy loss. So that is one more thing that we need to look into. Then there is anecdotal treatments going on, like immunotherapy and psychological therapy and all those things. But basically, we have already covered low molecular weight heparin, low dose aspirin, and prednisolone, folate, progesterone. These are the mainstays today. By and by, as we go forward in the discussion, we will answer specific questions on each of those drugs that I talked about just now. But please remember, again, I'm reiterating DNA fragmentation test for sperms. Thank you.
Thank
Hello.
you, Dr. Rajneesh. Would
Yeah.
any-
Dr. Niranjan,
Yes, please.
may I
comment.
add to this? May I add to this?
Yes, yes. Rajiv Lal and then Dr. Sandhya. Yes.
I think that the unexplained causes need to be reduced, and for that we must send the products of conception for karyotyping, not only karyotyping but for comparative genome hybridization by arranged in microarray, because banding technique will assess only structural and chromosomal rearrangements, and they are likely to fail because of contamination, culture failure, and overgrowth of maternal cells. But entire genome sequencing can be done by CGS, and which can detect micro duplication and micro deletions. So in unexplained RPLs, the cause can be identified, and even if the abortus is normokaryotype reported previously, the cause then can be genetic. And if entire genome sequencing is not possible, exome sequencing, that is studying the variations in the protein coding in the region of any gene, should be done. So in patient of RPL, I would suggest sending POCs for comparative genome hybridization in microarray.
We'd just like to round off what Dr. Lowell says, is the third abortus should be sent for genetic CGH. And if that CGH comes back as normal, then we should go in for karyotyping of both the parents to look for Robertsonian translocations. That's all. Yes, Sandhya.
Dr. Sandhya.
I'll just add one thing. Thyroid also plays a very important role. In my practice, I see a lot of patients who are hypothyroid or who have subclinical hypothyroidism. So this is one thing. Now the guidelines have changed. Initially it was 4, the TSH levels which we took into account, but now by and large we have come down to 2. Niranjan, is that this patient has come to you. Now you have taken an elaborate history, you have ordered so many investigations, but you need to ask the patient about their social history. The environmental history is very important. Many a times nowadays you have patients smoking a packet of cigarettes, who are drinking, binge drinking, and then they're doing all kinds of things. So environmental toxins have to be ruled out. You have to at least give them some kind of a counseling. I do not say, because if you do not tell them, they may not even divulge this kind of history to you. So it's very important that you tell the patient to be transparent, advise them, because there is definitely a correlation between smoking, alcohol intake and caffeine intake. So it is recommended that the caffeine intake should be restricted to less than 3 cups a day, and alcohol intake and smoking absolute cessation. So this is TLC is what goes a long way in helping these patients.
Wonderful, Dr. Sandhya. You have covered everything. Anything else anybody wants to say?
I would also like to just emphasize that, the guidelines, there are 3 recent guidelines as recent as 2017. One is the ESHRI, one is RCOG, and the ASRM, American Society of Reproductive Medicine. All these are very strict protocols as to what you should do. There is something like strongly indicated, may be indicated, or probable. So everything, all this genetic analysis and all, it is not mandatory. It can be, if it is possible, because there is a lot of maternal tissue contamination in the POCs. And even the microarray techniques, sometimes they are not very conclusive. So definitely, and also the main thing is treatment, pre-genetic screening and pre-genetic diagnosis, implantation. All that is something which can be given, but it is not mandatorily recommended.
Yes, Datta.
Yeah, I have 2 questions, one for Rajneesh and one for Dr. Laul. Rajneesh talked about the very important male factor. So I want to ask him, how do you interpret this test and what is the treatment if this is abnormal?
Hello.
Yeah.
My voice is gone completely. I don't know for what reason. Lowell, Dr. Lowell, you answer.
Dr. Lowell, please take over.
Hello. What is the question for me, Dr. Datta?
For you, the question is, sir, you talked about this autopsy and the genome and the exome test.
Yeah.
So how do you interpret this test again, and how is it going to help us in the future pregnancies?
See, if you get the cause, suppose if the POCs are sent for a complete genomic hybridization, then you can detect even micro deletions and micro duplication. So once the problem with RPL is we don't know the cause in 50%. Once we know the cause, we can stop all those tests. We know that this patient has genetic factor. So then you treat that genetic factor. Means suppose then you can offer them a PGD diagnosis, or you can advise them donor gametes. If they are, and also some of these couples may conceive spontaneously also. So without doing all those investigations, they will conceive spontaneously also. So just karyotyping will miss a lot of diagnoses where genetic factor is involved. So that's why instead of doing just karyotyping, you should do comparative genomic hybridization, and that will give you clue how to proceed further. Because there is so many tests that it can be very demanding for the patient to do all these tests.
Yes, thank you.
Can you repeat your question, Datta?
Yeah, I want to know, you talked about the male factor, the very important male factor.
Yeah.
I just want to know, how do you interpret this test, and what is the treatment if the test is abnormal?
Yeah. So the DNA fragmentation test actually sees the individual fragmentation of the DNA inside the sperm. Whereas when you just do a normal sperm assay, You just look at the number of sperms and the motility. They give you a range of 0 to 25%, 26 to 50%, and more than 50 and 74% and above. So the percentage of damage reported in the DNA fragmentation test tells you how fertile the semen is going to be. Understand? They give you a chart. They'll give you a chart, percentage of DNA damage and fertile range. So accordingly, you can interpret that test. The only treatment we can give is the antioxidants. There's nothing much we can do about it unless we find some chromosomal translocations in the
Along with that.
karyotype.
Yes.
Otherwise, we have to go for donor semen.
Yeah.
Can I add something?
Yeah, yeah.
Yes.
please.
The microarray
Then we
and
move on to the
neuron
next.
testing will help in pointing out what are the chances of repetition of same defect in future pregnancy. And the genetist can do a counseling to the couple.
Yeah.
Okay.
Thank you. Thank you. Now we go to Dr. Laul. Sir, in women who are presenting with a clinical diagnosis of threatened miscarriages, does the use of natural micronized progesterone reduce the rate of spontaneous miscarriage?
Sir, a PRISM trial was conducted, which was a randomized double-blind placebo-controlled trial by Professor Eric Kumaraswamy at National Research Institute on Miscarriages. He found that there is a considerable reduction in miscarriages for those with 3 or more previous miscarriages in early pregnancy with bleeding PV when micronized progesterone was given vaginally in the dose of 400 milligrams twice a day, while the small reduction with 1 or 2 miscarriages with bleeding PV in early pregnancy, and progesterone did not reduce the rate of miscarriages for those with no previous miscarriages. So progesterone will definitely help in that patient with 3 or more miscarriages in early pregnancy with vaginal bleeding, because the earlier PROMISE trial has said that progesterone has no effect on reducing miscarriage rates in patients of RPA, which was very, very disappointing for people like me who are regularly using progesterone in RPA. So the use of progesterone will improve endometrial blood flow, endometrial receptivity, uterine microenvironment, and also will act as an immune modulator in reducing immune rejection of the fetus by increasing the expression of progesterone-induced blocking factor, preventing NK cell-induced cytolysis and receptivity of membrane receptors, and increasing activity of Th2 and decreasing this dystrophy, immunodystrophy.
Amazing answer, sir. You have done good justice to this question. You have taken a lot of efforts. I can see that, to go through the various trials, and also you have explained at what is the mechanism of action it will act. And yes, it was disappointing initially, but now most of the trials which have come out, especially in this decade, in 2016 by Ray, and we had a trial also by Haas, where another Cochrane review of 14 clinical trials were done, and they evaluated the efficacy and safety of progesterone, and it was reported in also subgroup of women with prior 3 or more consecutive miscarriages. It favored and statistically significantly favored the use of progesterone. And there is one more also, a meta-analysis of 10 randomized control trial which was involving about 1500 women, and they were given this supplementation with progesterone, and they found that it helps in lowering the risk of recurrent miscarriages and higher chance of live birth. So thank you, Dr. Lowell. You have done a wonderful job of going through all those articles also. I just added few of them. Thank you so much. We come to now Dr. Sandhya Saharan. Madam, what is the effectiveness of using natural micronized progesterone in women who are undergoing ART? Any one of you also can answer after Sandhya, and they can give a message. The use of patients who are coming with failure of conception, and they are going from one pillar to another pillar, and then there is losses which are occurring, and then you have ART, which is the last option. So, what would be your take, Dr. Sandhya?
Yeah, Niranjan, before I answer that, I'll just touch upon for a minute on the theoretical aspect. Basically, why does progesterone help? As we all know, it induces a secretory changes in the endometrium, makes it more receptive to the embryo implantation. So what we have to remember is that it relaxes the uterine wall. It makes it from an inflammatory reaction to an anti-inflammatory response. It immunomodulates the endometrium. We have seen that it is basically the T1 cytokines, which are initially responsible for inflammatory response. So it changes the milieu to a T2 kind of a response, and also decreases the activity of the natural killer cells. So basically both are the actions of progesterone. Now, as Dr. Lowell said, I'll just add a bit to that. Now this PROMISE study, which was, it got over in 2015, if I remember, and it was only in 826 women, where they found 63% in the treated group, whereas in the other group they found only a difference of 3%. So that is why they said progesterone is really of no value. Now this PRISM study, which is done in 4,153 women in 48 centers in UK, which is with Birmingham, this has shown us a great result, and this is going to be incorporated in the NICE guidelines. Now coming to ART, we all know that in ART we use gonadotropins, we use agonists, antagonists, clomiphene citrate. Everything has a detrimental effect on the luteal phase. There is always a pituitary luteal phase suppression. So when there is inadequate progesterone, then definitely it hampers your implantation, it hampers the progression of a normal pregnancy. So progesterone is very important, I would say, in these patients who are undergoing ART. You can start it from the time when you give your trigger, or when you're doing your IUI. Suppose you're doing IUI, I like to start it the moment I finish my IUI, I start my patient on progesterone, and then I continue it, because the corpus luteum, as we know, it can only sustain it till say 7 to 9 weeks. Following that, the placenta takes over. So at least for first trimester, I do suggest that we continue progesterone. Some people like to continue it up to 28 weeks also. So ART patients, definitely natural micronized progesterone is very imperative. Now there are various preparations. You can have oral, you can have vaginal preparations. Nowadays you have tablets, effervescent vaginal tablets, 100 milligrams, they can be used, or you have, I definitely don't prefer depot preparations anymore, but I would say either oral or vaginal preparations.
Okay, thank you, Sandhya. Dr. Rajneesh, would you like to add something here? Or that's fine? Great, thank you. So, Sandhya, you have done a wonderful job, and you have given a nice use. Anybody is practicing ART here in our group?
Uma.
I am practicing.
Yes, Dr. Uma.
Yes. What Sandhya says, yes, micronized progesterone up to 12 weeks of pregnancy. If no other risk factor, then I don't continue further, but definitely till 12 weeks of pregnancy, because there is a lot of hormone disturbance in a stimulated cycle, or even in frozen thaw embryo cycle.
Okay, thank you. Thank you so much. Now we go to the next question. Dr. Uma, this question is for you only. Can you clarify on low molecular weight heparin used in women with inherited thrombophilia, and what are the guidelines? Do they recommend it or they don't?
Okay. As I done in my presentation, that inherited thrombophilia should be investigated. Whenever we talk of unknown factor, because we are not investigating many times, and we say it is unknown factor. Now, Ormishar et al. In Women Health in July 2016 have presented a paper where the ACCP guidelines does not recommend routine use of LMWH in inherited thrombophilia. But they are saying that it is on the clinician discretion. But RCOG guidelines recommend consideration of antenatal prophylaxis in asymptomatic patient with homozygosity of factor V Leiden and prothrombin G20210A mutation. This guideline also recommends prophylaxis in women with antithrombin, protein C or protein S deficiency, despite absence of personal or family history of VTE. So not necessary that there is a history of embolism in the past, but if patient is having recurrent miscarriage, RCOG is recommending use of LMWH. In such cases, due to lack of good quality evidence support for the inherited thrombophilia, it is on the clinician discretion whether they want to use LMWH or not. But as I mentioned in my presentation, that if the protein S or protein C level is less than 50%, definitely these patients need LMWH as a thromboprophylaxis.
Thank you. Thank you so much, Dr. Uma, for that wonderful
And
insight.
LMWH also help in assisted conception treatment because thrombosis will affect the implantation also. So it can be a cause of recurrent implantation failure. So inherited thrombophilia, LMWH prophylactic use is recommended.
Thank you, Dr. Uma, for that comment. And now we go to Dr. Ashutosh Asgaonkar. Sir, how different is the oral administration when compared to vaginal progesterone when we do the supplementation in luteal phase support? What is your opinion on this? Dr. Ashutosh.
Can't see him.
I think his video is off.
No, I think he's logged off. We'll wait for him to log in again.
He is logged out. He might have got a
Emergency call, maybe. Who knows?
emergency call. Anyone can take Dr.
Hello.
Dr. Rajneesh.
Yeah.
What do you feel on this issue, whether oral or vaginal?
Well, as Dr. Lowell said earlier, I also use micronized progesterone regularly in my practice, and thank God that recent research is now pointing towards some benefit in it. Otherwise, we used to go to all these webinars and we used to be derided by everybody present there, 5 years back, 3 years back. क्या सब लोग प्रोजेस्टेरॉन लिखता है, काम धंधा नहीं है, etc. So anyway, coming back to my practice, in my practice, I don't know. I mean, I'm working in a place which is a slightly lower socio-economic strata. Giving any vaginal tablet is asking for non-compliance. One has to remember that even if research says that vaginal micronized progesterone may work better than oral micronized progesterone, one has to be aware of the ground reality. And if your patient is not putting the tablet in the vagina, she's not getting any progesterone at all. Instead of that, you are better off giving oral micronized progesterone. So I would tailor it according to the patient's need. Instead of trying to decide on my own which is better, I would ask the patient, and if she is happy with the vaginal tablets, I would definitely give her vaginal tablets. Otherwise, I would go with the oral.
Hello.
Yes.
Dr. Niran, oral route is easiest, but progesterone is degraded in liver with extreme variability in plasma concentrations, and there are side effects such as nausea, headache, and sleepiness, which can be avoided by vaginal administration, which avoids hepatic metabolism. There is rapid absorption with higher bioavailability, local endometrial effect. It is not painful, but the problem is patient may feel uncomfortable, and with bleeding it is very difficult. So preferably vaginal, but if patient objects, then oral will also do. Or if vaginal is not working, we can also consider dydrogesterone orally.
Or as Uma said, hydroxycaprate depot.
Yeah.
Depot hydroxycaprate also works.
That injection is very painful.
It is very
Yes,
painful.
it
Very
is painful.
painful. Micronized progesterone is a much better option according to me.
Okay.
May I add here?
I think-
Vaginal progesterone is better than oral progesterone But if
Absolutely.
patient is bleeding, then either dydrogesterone or injection. Once bleeding stops, go back to vaginal microprogesterone. That's what I do in my practice.
Okay.
Madam, I agree with you. When my mother also started, we had hydroxyprogesterone and we have got that injections. But I think now since last 10, 15 years, we have got this micronized progesterone and I think it was started probably Walter Bushnell or I don't want to take any names, but surely it was a game changer and now it has been used very often and we are using it left, right, center. Micronized progesterone are going to stay here for a longer time, I'm sure. Obviously, there are going to be various other modalities. Oral is also one of the option, but I think in ART and in the recurrent pregnancy loss, obviously, if it is not bleeding, then we would prefer to have this micronized progesterone. Dr. Datta Panandikar is the secretary of Thane Obstetric Gynec Society. He is himself a legend there. With I think this might be your third generation or fourth generation Datta. Second generation. Yes,
Second.
second. So I remember your father when we used to come to campaign, and the best part I'll tell you now. I'm still the associate member of Thane Obstetric Gynec Society.
Yes, very much.
Yes, yes.
Yes.
And you are welcome
And
to
you
stay.
will remain. You will
You will
remain.
remain.
So I'm always there and I get all those messages of Thane Society. What a wonderful people you are. Dr. Godbole, Dr. Devdutt, Dr. Karkhanes, Dr. Pawar, Dr. Bhagwat, Dr. Rekha Thote. And there are so many of them, Dr. Vaidya, they're so wonderful people. And something or the other is going on, some musical show or some singing competition. Some, Aji, famously known as Aji,
Yeah.
she's so nice. And there are so many things or the other extracurricular activities going on. And I like that wonderful experience. So whenever I'm sometime in the evening or in the night, I just go on TOGS Fun and Masti and I find wonderful recipes and I find wonderful songs and YouTube videos. Thank you so much that it was being, with you. And I'm sure I might have missed out some names, but I'm really connected with you all, especially though you are now a separate society. But we have still few questions to answer and there are audiences which are there. They are still with us. And well, I would like you to give one take-home message before we leave the show. One sentence which you can impart, all of you, starting from Dr. Rajiv Lowell, then we go to Datta, then Rajneesh, and then others. As what one sentence you would like to advise to your colleagues in Thane, and it's been heard all over India, pan India.
Try to find out the cause of RPL diligently. Think about sending products of conception for microarray and do the relevant test. The test which patient can do, the test which are necessary. For example, if 3D sonography is available, all the anatomical factors are covered in one shot. You don't need hysterosalpingogram. Then if the conclusion is genetic factors, then we did not do all the other investigations. And also take into consideration environmental factors. Because once the cause is found, half the job is done. Then we know how to treat it. Otherwise, everything becomes a shot in the dark. If you don't know the cause, then every treatment becomes empirical. Thank you.
Wonderful, wonderful, sir. Yes, Dr. Datta.
Yes. See,
take-home
from
message.
from all these things, eminent speakers that I've heard, 2-3 things we have to emphasize on each person as a take-home message. Number one, Dr. Lowell telling us repeatedly, get the products of conception screened. Number two, Rajneesh telling us that you have to don't forget the male factor. The sperm fragmentation test is so important. Uma has given a wonderful slide on the dose of LMWH according to the weight. I have found myself two sets of consultants. The ARD consultants like Uma will always go for vaginal progesterone. And the non-ARD consultants like me will always go for oral progesterone. These are two different sets of consultants. What I have found, see, there will be a certain percentage of patients who, in spite of doing all this, giving your ecosprin, giving the natural micronized progesterone, will still continue to abort. And we are clueless about that. What I found was 10 years, about a decade back, most of the IVF consultants started adding estradiol valerate 2 milligram in the dose of 3 times a day in their protocol. What I'm doing is the women who are continuing to abort in spite of the routine treatment, I add tablet estradiol valerate 2 milligrams 3 times a day, and 90% of these women are not aborting in the first trimester. I have no study to substantiate my claim. If you ask me what is the scientific basis, I don't know. But I'm doing this. It's a practical point for all the consultants who are listening. If you have patients who are continuing to abort in spite of doing everything, try this. Your patient might go to term. Thank you.
That was great.
Yeah. Dr. Rajneesh.
Yeah. Although you asked for one take-home message, I have got two. The first one is that everybody please increase the dose of aspirin to 150. It has been proved beyond doubt now that the blood platelet response, they found out in the coronary artery disease patients, and we are sort of taking a cue from there. That in the coronary artery disease patients, they have found that the blood platelet response to 75 was suboptimal in some cases, and increasing the dose to 150 removed that. The theory behind it is that increasing the dose to 150 also covers COX-2 activity. As you all know, in the prostaglandin cascade, there is COX-1 and COX-2, and 150. Making aspirin to 150 covers COX-2 as well. That is the first thing that I want to tell everybody. Second thing I already told, but I just want to remind, please do DNA sperm fragmentation tests. Thank you.
Yes, Dr. Sandhya.
Yes, Niranjan, I will again emphasize on what is very close to my heart, being a strong proponent of lifestyle modification. My take-home message is that you have to tell your patient whatever you do, this is only what you can manage. So stress, it plays a very important role. I would advise lifestyle modification, diet, exercise, meditation. See, RPL is a test where the doctor and the patient tries to give in their best, but at the end of the day, you remember, leave God to do the rest.
Nice one.
Dr. Uma.
Yes. I would like to say LMWH is a safe drug. It can be used effectively in thrombophilia. If patient is acquired or inherited thrombophilia, LMWH will make wonder for those 6 lakhs pregnant patients in world who is having thrombophilia and recurrent pregnancy loss. It is very safe provided dose is used correctly. And here I mentioned in my presentation that the dose should be according to the weight. And second thing, there is a difference between therapeutic dose and prophylactic dose. So if a patient is having history of VTE, then it should be therapeutic dose. That is what I want to give take-home message, not prophylactic dose. And another comment from on Dr. Datta Panandikar, where he has mentioned use of estrogen. I feel, Dr. Datta, it is because we are using overuse of progesterone. So balancing estrogen with progesterone, we don't know whether it is deficiency of progesterone. We are maintaining a hormone balance, and that may be the reason that if it is due to hormonal disturbance, these patients adding estrogen, they have a better chances of continuing pregnancy. That is what I feel.
Thank you, Dr. Uma. There are various questions. Many questions are there. There's one question for you. What is the role of HCQ in Uma ma'am's case? Is it safe throughout pregnancy?
HCQ is very safe in my patient particularly. She was SLE also. So in SLE cases, you have to give steroids, and she was on Visolon 5 milligram. Here I have a question to all of you, which is a question in my case. In my case particularly, the patient dose was reduced to 60 milligram per day because of the hematoma. Now at 31 week, she is showing sign of early IUGR. I had this question to even hematologist also, that why don't we increase the dose again from 60 milligram to at least 1 milligram per kilogram body weight, because she is 70 kg now, though the therapeutic dose is 60 milligram BD. So my question to all of you, would you like to increase the dose, or it is acceptable that okay, patient, if she deliver early because of IUGR before 34 weeks of pregnancy, baby going in NICU is fine, rather than patient is having another episode of bleeding? My question is open to you all. If I hope you have understood, Dr. Chavan, what I mean to ask,
Yeah.
We understand.
because it is a discussion. I feel we
Let's go
should
one
clear
at a
our
time.
things.
Let's go one at
Dr.
a time.
Datta, what you say?
Yeah. I do not think at 37, at 31 weeks, increasing the dose by 60 to 120 is going to make a difference to the overall outcome of the baby weight and probably the time when you are going to deliver her. So I think increasing to 120 is taking a slight risk of another episode of bleeding, and I would probably continue her with 60 till finally it's time for her to deliver you, because we have got excellent neonatal facilities now, and even 1 and 1.1 kg 29-30 weekers are going home very regularly in Thane. So I don't think it is really worth increasing the dose.
He is on 60 milligram at present.
Yeah, continue on 60, correct.
I tend to agree with Datta.
And then Dr. Rajneesh, and then we will end the program.
Yeah.
Thank you.
I would like to agree with Datta about this. And the second question, that the counter question to Uma would be, placental circulation has already been established in toto. Unless and until there is microthromboembolism working as a factor for the IUGR, how sure are we whether increasing the dose of heparin will increase the blood flow to the baby? There might be other causes of IUGR at work there.
I fully agree with you. I fully agree with you. That's why we are continuing on 60 milligram. My only doubt was, when we have reduced to 60 milligram OD, if after the hematoma was resolved completely, should we have gone back to therapeutic dose, because she had CAD, angioplasty done, she had 2 episodes of thromboembolism in the past. That was only my query.
We have already missed the bus.
Now, yes, now it is missed the bus.
Yeah.
It is for future. It is for future.
Yeah.
So thank you, all of you. It was a
Sandhya,
pleasure. Sandhya, last comment.
First of all, HCQs, efficacy, safety. We have a lot of patients with rheumatoid arthritis who come to us. We routinely, they are on HCQs already, and we have not seen any problems with them. They have delivered up to term also without any side effects. Secondly, I would definitely not try to increase the doses, because we know IUGR babies fare very well even in the NICU. Vis-a-vis the risk of having a bleeding episode on your hands when you are having a patient who comes with a full-blown bleeding episode who is on heparin, and suppose you need to section her immediately, it becomes very difficult to control the blood profile and to manage her post-operatively also.
Thank you. Thank you. It was doubt in my mind. That's why I thought we should clear it in the panel.
Definitely.
Yeah.
Madam, there are many questions, sir and madam, and I can tell you, I have done shows now for Surat, Valsad, Kolhapur, Karad, even other societies, Trichy,
Navi Mumbai.
and Navi Mumbai, and then Thane. But I think at this district level program, which is only for RPL and for particular our own societies, this show has gone more than 2 hours. I think you have broken all the records. And such a wonderful discussion has occurred amongst ourselves, and there are questions still there. But I would like to thank all of you. All of you are so wonderfully well read. Amazing discussion which went, and it went for more than 2 hours. and I'm sure I can still recollect all those wonderful and beautiful memories. I have visited at Thane, United 21, and other places, Cure Hospital, and such wonderful people you are. And it's been such a wonderful time. Yes, Rajneesh sir, I have come for your installation also, and I could not come for Rajiv Lal sir's because it was lockdown period, and in this lockdown period, all of you have been such amazing. Yes, sir.
All I wanted to say was a lot of credit goes to the moderator too. A lot of
Yes.
credit goes to the moderator too. You have done a great job. Thank you so much.
Niranjan, you will come for my installation next year.
Yes, yes, I'll be there. All of us will be there, and we will be hopefully having a wonderful ceremony for Dr. Rajiv Lal also. Hopefully, I will be there. Hope all these things end soon.
If you find any pertinent,
This image here, which has been showcased on the screen, so you have to buy less, choose well, and make it last. So what does it say? It means that you have to buy with less time. So we have more time. Think before choosing what is important, because time once spent is lost forever. Choose well, make it last, and you have to celebrate, cherish, treasure whatever we get from spending the most valuable ever depleting resource, which is called time. So wishing you all exciting, interesting, wonderful, satisfying, fruitful times ahead, and Shabba Khair. Have a good
Thank you.
time.
Thank you,
Thank you.
Dr. Niranjan. Thank you. Thank you very much.
one last thing, Niranjan.
Thank you so much, all of you. It was a wonderful time spending with you. I would like to thank the sponsors, Bharat Serum, Subbu, Anuja, Session from Science Integra, who were there. And next time we will come home and I will have dinner with you sometime soon.
Yeah, sure, sure.
Thank you. Thank you so much.
Thank you very much. And Dr. Chavan, Talks is not a society, it is a huge family.
Family, yeah.
It is a huge family.
Well said, Uma.
Yes, yes, we all agree to this.
Yes. And I want you to come also to my home. I invite you when everything goes fine and we will have dinner together.
Sure.
Yeah.
Thank you so much, doctors. It was a pleasure having you all on the platform.
Yeah. Dr. Rahul, do you think we can extend the session by 10 minutes and answer the pertinent questions from the audience instead of the...
Doctor, where is Dr. Niranjan?
Sir, I'm here only. I'm listening.
Bola,
If there are any pertinent questions.
if you find that any question has not been answered, any topic
Sir,
which
it
has not been...
all been covered because I went through all the questions. They're all repetitive. You have covered anti-phospholipid. We have covered Uma Madam's question.
Good.
And we have covered the heparin along with that is low molecular weight, the dosage. We have also covered the aspirin, how much to give in a normal patient and in an overweight patient. And I think Datta has summarized everything nicely and each one of you have given take-home messages.
Good.
So we should be satisfied with that.
Yeah, because at the end of the day, the audience matters more than
Yes, and due to paucity of time, we covered all those questions, not only during the which has been already told to you, but we have covered all aspects. So I think
Thank you.